Well, what are some of the pitfalls in the diagnosis of ectopic pregnancy? Well, I've just described probably the most common, which is the problem that you have diagnosing an ectopic pregnancy at a very early gestational age. Another problem is poor visualization, and this can be due to obesity, the presence of fibroids in the uterus, a retroverted uterus, myometrial contractions, artifact from bowel gas, and also inexperience of the examiner. The presence of coexistent adnexal pathology can also decrease your ability to evaluate the pelvis and identify an ectopic pregnancy. So a patient who has a dermoid or some sort of adnexal mass, again, it's just harder to visualize any other adnexal structure. But another very common problem is the difficulty in differentiating a corpus luteal cyst from an ectopic pregnancy. There are several things, though, that you can use to help you make that differentiation. First of all, the corpus luteal cyst is intra-ovarian in location. So you ought to see a rim of ovarian tissue around the corpus luteal cyst, and this has been determined or described as the claw sign, as opposed to an ectopic pregnancy, which is adjacent to the ovary, and therefore the structure should have an acute angle with the adjacent ovary. Another thing that has been described is that in general the wall of the corpus luteal cyst is thicker, more regular, and more hypoechoic than the wall of the ectopic pregnancy, although there is certainly overlap with the ring of the ectopic pregnancy, which tends to be a little bit more echogenic, similar in echogenicity to the endometrial stripe or the ovarian stroma. But again, while those are tendencies, there is overlap between the two appearances. And the last thing that you can try and do is dynamic scanning, namely to try with your hand pushing on the anterior abdominal wall, try to separate the two structures. And if you can separate them, you know that you're dealing with an ectopic pregnancy and not a corpus luteal cyst, because the corpus luteal cyst, of course, is part of the ovary and therefore will not be separable from it. So here are some examples of the typical appearance of a corpus luteal cyst. You see a very homogeneous, thick-walled structure, often very vascular and relatively hypoechoic. Sometimes it contains some hemorrhage or debris. You can see some fibrin stranding or some internal echoes within it. Here are another couple of examples showing that you sometimes can see free fluid around the corpus luteal cyst, but again, a very homogeneous, thick, almost wet-like appearing hypoechoic ring-like structure. Notice it can be extremely vascular, and although the term the ring of fire was initially described or proposed as a description of an ectopic pregnancy, in fact, it's been my experience that you can see this completely circumferential ring of blood flow. That's much more common to see in a corpus luteal cyst than in an ectopic pregnancy. In my experience, in an ectopic pregnancy, that color flow tends to be a little more segmental. The other thing is that you sometimes see this stellate or star-like appearance of a crenated corpus luteal cyst, and when you see the inside again having this pointed or triangular margins as that cyst wall seems to collapse on itself, that's again a very classic appearance for the corpus luteal cyst. This is an example of the claw sign. This patient was pregnant, had an intrauterine pregnancy, but had some left-sided pain. Here you can see the left adnexa. Here is the ovary. There's obviously a cyst here with a lot of hemorrhage and debris within it. You note that there is a lot of vascularity within the cyst wall, not as thick as those other corpus luteal cysts, but the reason that I'm confident that this is a corpus luteal cyst and not a heterotopic ectopic pregnancy is that I can see this claw of ovarian tissue or ovarian parenchyma surrounding part of that cyst. That confirms that that cyst arises from within the ovary, and if I can tell for sure that the cystic structure arises from the ovary, I am virtually certain that this is a corpus luteal cyst, as intra-ovarian ectopic pregnancies are extraordinarily rare. Here are two different patients demonstrating the classic difference between the corpus luteal cyst and the ectopic pregnancy. Notice that the corpus luteal cyst, while it has a vascular wall, it's relatively hypoechoic. There's ovarian tissue around it. You can see this crenated appearance with some debris within. And the patient on the right that has an ectopic pregnancy, you can see that the trophoblastic tissue is extremely echogenic, much more echogenic than the corpus luteal cyst. You can see an acute angle between the ectopic pregnancy and the adjacent ovary, although there's a little hemorrhage between the two structures. There's no claw of ovarian parenchyma surrounding the ectopic pregnancy. So again, in general, ectopic pregnancy is much more echogenic than the corpus luteal cyst, although there is overlap. And then the last thing you might try and do is dynamic scanning, and you push on the anterior abdominal wall and you see if you can separate the cystic structure that you see here on the left-hand side of the slide from the ovary here on the right-hand side. And so with your hand, and this is a video clip demonstrating that as we push anteriorly, you can see that the ectopic pregnancy, which is very echogenic, moves quite separately from the ovary here, which is hardly moving at all, implying that this structure is separate. And if you look carefully on this video clip, you can see the edge of the ovary actually here, and this is just some hematoma between the edge of the ectopic pregnancy and the edge of the ovary. And again, dynamic scanning can be extremely helpful in determining whether structures are separate from each other within the adnexa. However, color flow imaging and the pulse Doppler waveform characteristics are not helpful in differentiating the exophytic corpus luteal cyst from an ectopic pregnancy. Both will demonstrate increase in peak systolic velocity and increase in end diastolic velocity, the so-called trophoblastic flow, and both may demonstrate that ring of fire. So again, the Doppler, either pulse Doppler and color flow characteristics are not helpful in differentiating those two structures. So to reiterate, as many as 8 to 25% of patients with ectopic pregnancies will have a normal endovaginal ultrasound initially, particularly if you evaluate them early in gestational age. These are those so-called pregnancies of unknown location that we've talked about earlier. So it's important to remember that follow-up imaging, serial beta HCG levels may be required in order to make the diagnosis.